and some of our underused practices. As we've been talking about, cesarean rates are high and rates of vaginal birth after cesarean are low. That's been a big change. I've been doing this like 20 years, and in the mid-90s, late 80s, when I was doing this work, I assisted a lot of women in having vaginal birth after cesarean. That's just changed in the last 10 years. And assisted vaginal delivery rates are high, which is vacuum extraction or forceps delivery, and also it's almost unheard of that a woman pushes in an upright position in a hospital setting. This is actually me at a birth. Sorry for the graphicness of the picture, but we're talking about childbirth here, and I think hopefully we'll be able to handle that. But that is actually me at a birth helping a mother in an upright position, pushing, and that's her wonderful doctor right there, who was so thrilled when she walked into the room, because the head was on the perineum. She didn't care how it got there. She just was happy the head was on the perineum. Next slide. Again, this is a photograph of me assisting a mother in a water birth in a hospital setting. The family actually came in and set up the birth tub. This was a Good Samaritan, and the family labored in the birth tub. She actually had a Pitocin augmentation and water birth at the same time. She was getting her pain relief from water, and she was being augmented by Pitocin. So epidural rates are very high, as the Listening to Mothers survey told us that, and analgesic rates are high, and we need to do more to promote non-pharmacological approaches to pain management, such as water birth tubs in a hospital setting. I think this birth was the perfect example of how we could integrate technology with low tech. We can have both. It wasn't one or the other. And then, of course, continuous support from from professional labor companions, doulas, is an underutilized resource as well. And you probably know the studies show the presence of a doula reduces the need for pain medication, shortens the length of labor, reduces the need for C-section, improves bonding and maternal interaction, maternal-infant interaction. Next slide. Also, we want to encourage women to walk in labor. Walking in labor can speed up the birth process so that she wouldn't need augmentation. And have her have access to midwifery care. I think probably a lot of people here know that only 7% of births are attended by midwives in this country, even though we know midwifery care is associated with fewer C-sections and lots of other benefits. We also know that it's important for women to have a say in what happens to them during the birth process. We know that making choices around your birth has a long-term impact on bonding, attachment, and functioning for that mother really for her entire lifetime, and that's really well documented in the research. And it promotes maternal-infant attachment. And of course, exclusive breastfeeding. Karen will talk a little bit later. We have actually low levels of exclusive breastfeeding. And the task force and many hospitals are working on not separating mothers and babies, because we know that that will impact breastfeeding. We also probably never think about obstetrical interventions and how they impact breastfeeding. And if you come to our training, we're going to talk a lot about that piece of it. But that's a whole thing that we don't ever really talk about too much. So we want to reduce preterm birth, of course, and this is around having women have access to social support services, like doula care in the pregnancy. Programs like Black Infant Health Program have worked in having case managers that support those women throughout their pregnancy. Doulas are also great for that as well. We want to avoid routine interventions that are ineffective. We want to try to avoid induction of labor. Now the state is tracking how many births are induced as well as augmented. And I hear that as a shift in our consciousness, because that didn't used to be kind of on the radar screen. And now it's more on the radar screen that these are called complications of delivery, which that's just a shift in like the last 5 years, which I was very excited to hear. Episiotomy is not needed many times. Most of the time, it's not a necessary intervention. instrumental delivery with vacuums and forceps as well. If a mother doesn't have an epidural, and she can push in upright position, chances are she's going to be able to push her baby out. I've seen 11-pound babies pushed out with no instrumental deliveries because the mother was upright. And then we want to reduce admission to the NICU as well. That will be a huge cost savings. And then I wanted to just put this slide in here in memory of Dr. David Klein. He was an obstetrician at Cedars-Sinai, and he was a champion of mother-baby friendly care. He recently passed away just a couple of weeks ago. It's very, very sad. He was a huge champion of midwives and doulas and mother-friendly care, and he definitely bent over backwards to give women the kind of births that they wanted. And he is going to be sorely missed by everyone. So I just really wanted to honor him here in this slide. We need to cultivate more physicians like him. And now I'm going to hand it back over to Vanessa. Her being a nursing instructor, she's going to be able to talk to you a little bit more about the role of nurses in this whole change process.